So it's my great pleasure and honor to be with you at the centennial meeting of AMWA. I have to say I have really found it difficult over the past day and a bit not to entirely throw out what I was planning to say and the topic that you see in the program, because I just so intensely want to respond to all the speakers who have preceded me. And I probably won't be able to entirely avoid doing that. It's just been a terrific program so far, very provocative, and I have so many personal stories that connect with things that speakers have said, including my own experience with an engineering professor. I probably will succumb to telling that story. But for the time being, I'll stick to my script and say that it is my honor to represent the American College of Physicians at this meeting. 2015 is also our centennial, and I'll call your attention, if you haven't seen it, to the letter in your program from my successor as president of the college, David Fleming, congratulating AMWA on its first 100 years and wishing the organization the very best for its next 100 years. And I'm actually really going to focus primarily on that future look, because I'll argue that that AMWA, this collaboration, this collusion of women physicians, is, if anything, going to be even more important going forward. Though the numerical issues that I suspect were a critical consideration at the initiation of the organization have changed substantially. There are many things about healthcare, the practice of medicine, the context in which we work, that I will argue will continue to require the kinds of things that women bring to medicine and to healthcare more broadly. And in that context, the fact that our numbers are growing is a wonderful thing, what I will call a feminized workforce, sometimes thought about with some ambivalence, is, I think, a real strength. But we're going to have to pay attention to the strength that we bring as a collective, lest we be excessively calmed by the fact that our numbers are changing. When I graduated from medical school in 1977, there were 12 women in my class. And it was not a huge medical school class, so that was slightly over 10%. But we recognized we had to stick together. There's a fair amount of literature about minorities and how minorities behave depending on their numbers relative to the majority. So people in extreme minority positions will often do their very best to ignore the fact that they're a minority, because they don't have, there's not enough people for a sisterhood. So it's better to kind of put your head down and just do your best to fit in. At the number that I went to medical school, we immediately identified ourselves as a sisterhood. And in part prompted by this meeting, I've been reflecting on what a powerful set of experiences that I had. We had a women's group that met probably every other week before we got into our clerkships, and somewhat less frequently, but continued to meet when we were in the clinical phase of our training. Many of those, that small band, are still very good friends of mine. And I have to say, it was a wonderful time because the men in the class were actually very excited to be in medical school at this early inflection point. You've already figured out the dates, and this was just the beginning of the time that women were being sought after as medical students and ultimately doctors. And my male colleagues very much appreciated the chance to be part of this big social experiment. But back to the comments that I want to make. My first point, and it's almost goes without saying, though I hope I'll be able to point out some particular features of the change that's underway that you find interesting. But medicine, the practice of medicine and healthcare are changing in seismic ways. And just reflecting over the 35 years that I've practiced, there we have new diseases. I do a lot of HIV work, about which I will say more in a moment. We have new diseases, new medications, new technologies, new procedures, and entirely new ways of interacting with each other. And that rate of change will at least continue, if not intensify. The tools that we use are undergoing rapid change, and a lot of this is in response to the reality that the knowledge base of medical practice is reputed. I haven't tried to verify this myself, but it's reputed to double every 6 to 8 years. And so I have been in practice long enough that the volume of medical knowledge is something like 36 to 40 times what it was when I graduated from medical school. And the mental models, and I say this as an educator, that I was taught that I was taught about managing this information. You know, the little file cards, the peripheral brain, are totally obviously a lot of technology in support of our diagnostic and therapeutic work. So medicine is just overall much, much more technological than it was even 15 years ago. And as I said, that trend will just intensify. It has implications for us. I made the at the time, it seemed to be a feminist decision. Now it just seems to be a bad decision not to learn to touch type. And boy, am I sorry now. Now people actually don't go to typing class. My kids all learn to touch type by watching TV, talking on the phone, and typing on their computers all at the same time. But these technical skills are things that many of us who are a little bit older are continuing to have to consciously and with intentionality learn. But the more important point here, I think, is the effect that technology has on how our patients experience their medical care, particularly when they're in situations of, I'll say, crisis. And I'll come back and pick up that theme in a bit. But also, the way we deliver care is vastly more complicated than it used to be. You know, sometimes when I give versions of this talk with slides, I show a picture of a physician from the 50s sitting at the bedside, actually on the bed, of a ill young boy. The model being one doctor takes care of this patient in his home, perhaps in his office, in the hospital if the patient needs to be brought into the hospital. But one physician can manage the range of the needs of this patient and perhaps the patient's whole family. And I am sure I'm not offending any family physicians in the audience now when I say that while that's still an approach to care, really none of us can expect to provide all the care that an individual or a family would need. And many of us are helping provide care over substantial distances. Certainly that's a part of my work in global health. And fundamentally, what we are trying to do is quite different than what physicians were trying to do when AMWA was founded, because of something called the epidemiologic transition. The epidemiologic transition refers to something that is going on worldwide, has gone on since probably about the 1400s. And it refers to large-scale shifts from in the nature of what makes people sick and the implications of those shifts for population. So the phase one is a time when people's health is threatened by pestilence, things like the Black Plague and famine. And birth rates are high because death rates are high and population size is small. The next shift is one in which epidemics begin to decline for various reasons, but largely having to do with public health. And thank you. And the death rate begins to decline, so population increases. Eventually, but with a lag, birth rates begin to decline, and we've heard a bit already, and we'll hear some more today about the mechanisms by which people can control birth rates and the implications that that has for women and the populations that we live in. But birth rates begin to decline, and population levels stabilize, but at a much higher level. The third shift, and that's the one that has taken place in the States in the past 100 years, but is actually going on in the global South as well, is a shift to chronic illness and so-called man-made diseases. And those kinds of diseases require a different skill set on the part of physicians than the treatment of trauma and other acute illnesses. So to begin to wrap up and bring my points home, increasingly healthcare is going to become a job of keeping people well. And that sounds like a platitude, but it's actually going to become a even more challenging job than it already is. You've all heard the term precision medicine. And right now we think of precision medicine in relatively isolated domains, things like oncology. My husband is an oncologist, and we are seeing a lot of so-called molecularly targeted therapies in oncology. But there will assuredly be precision prevention. And we already have some examples of that. One that's familiar to this group is how we manage people with the BRCA1 and BRCA2 mutations. But this is an area that is already exploding. and is going to require us to become much, much more effective at health promotion and disease prevention than we have been to date. In fact, throughout medicine, there are many people who are unsure that disease prevention and health promotion is really what doctors ought to be doing. Isn't this public health? But at the level of individualized, personalized disease prevention, it sort of by definition can't be public health, which are general, broad-scale solutions. So I think that the kinds of orientations that women bring to healthcare, the broad way that we conceptualize our role, I'm generalizing here, but I think it's, like many generalizations, fundamentally accurate. We see our role broadly. We work well in teams. We listen well, a critical skill in health promotion. Will really be essential physician skills in the coming 100 years, in AMWA's next 100 years. The other point that I would like to make here is that it will be increasingly obligatory that we humanize technology. We're very comfortable in the environments in which healthcare is provided, with the monitors and the alarms and the flashing lights. But these are terrifying environments for people who are ill and their families. And our role as explainers and as mediators and as humanizers, I think, will be, if anything, increasingly important. I was so glad to hear the remarks reiterated in talk after talk, and most recently in Dr. Clayton's talk about advocacy, because I think the fourth thing that we need to do is to continue to engage on our patients' behalf, but on our own behalves as well, in making the world of healthcare work better for them and work better for us. While we have seen much improvement, the medical school where I teach has had 55% women in the matriculating class for probably 25 years now. We still don't see women in leadership positions at the rate we should. We still have salary inequity problems. I cut my teeth on salary inequity at UCSF in, this was probably 1984, and it was the second damn salary inequity study. I don't think we've seen a huge amount of change. So we need to be humanizing on one hand, and we need to be fierce on the other. And our patients need that from us, and we need it for ourselves. And I'll close just by saying that it's really striking to me to reflect on how influential AMWA has been. It's really quite remarkable given the size of the organization. Now, American College of Physicians is, give or take, 140,000 members. Pound for pound, you guys pack a whole lot more punch. I really congratulate you. I think that has to do with the power of women organized in the name of women to tackle problems in service of others. And I would really encourage all of us to stick to that as AMWA goes into its next 100 years. So thank you very much for the honor of addressing you. I really appreciate it.